પછી બી में तो
So hello everyone. So this is Dr. Akif. We are going to start our case presentations for MD and DNB General Medicine students. So the presenter is Dr. Devapriyo and the moderators will be myself, Dr. Naveen and Dr. Deep. So we three are available. Okay. So we'll start with the session right now. Any questions anybody have, you can comment in the comment box, or we'll take questions at the end of the session. So presently only presenter and the moderators will be asking questions here and there.
Okay, sir, I'm
Okay,
starting now.
Devaki, you can start now. Yeah.
I'm going to present the case of Mr. Rajendra Sharma, 68-year-old male, resident of Varanasi, Uttar Pradesh, who is retired teacher by occupation, who was admitted on 15th of January and examined on 16th of January. He is right-handed. Informant was wife and information was reliable. He presented with chief complaints of palpitation on and off for 1 week, weakness of the right upper and lower limb of the body for 2 days, difficulty in speaking for last 2 days. In history of present illness, Mr. Rajendra Sharma was apparently normal in his usual state of health, performing routine daily activities, presented with complaints of palpitation started around 1 week ago, on and off in nature, described by the patient as rapid and irregular, with no episode of pounding in the chest or a strong single beat sensation. It was more noticeable on exertion but can also occur at rest. No specific precipitating factors such as stress, caffeine, or heavy meals were identified. The patient reports that sensation initially used to subside spontaneously, but duration of symptom increased in the last 3 days. He had also experienced self-limiting palpitation in the past, but those were of very brief duration. Palpitation has improved currently after admission and initiation of treatment. Patient described a sensation of ear hunger without associated chest tightness or wheezing, no orthopnea, paroxysmal nocturnal dyspnea, no hemiparesis, no cough or sputum production. There is sudden onset weakness in the right upper and lower limb, which began abruptly 2 days prior to admission. He was alright when he went to sleep around 2 pm, following which he had a fall at 4 pm. When he tried to get up from the bed, following fall, he noticed weakness in right upper and lower limb, such that the patient found difficulty in holding glass of water, however, was able to raise the arm. Patient also noticed weakness in the left lower limb, such that the patient needed support to walk, found difficulty in gripping his slippers. It was insidious in onset and gradually progressive over 4 to 6 hours. The weakness slightly improved since onset and stable after the onset since 1 day. No episode of worsening or improvement beyond slight recovery in limb strength. It was not preceded by trauma, exertion, or any significant stressor. Weakness was associated with difficulty of speech that began simultaneously with weakness. He was unable to speak, however, was able to understand the words spoken by his wife, could identify objects. Patient was further brought to the emergency department at around 10 pm in ambulance, during which patient noticed the weakness of right upper limb to progress such a way that he was unable to move the limb and weakness of lower limb remained same with feeling of heaviness requiring support to work. There is no history of blurring of vision, double vision, deviation of angle of mouth, drooling of saliva, difficulty in chewing food, no history of bleeding from nose, ear, or any discharges. He denies any history of headache, nausea, vomiting, aura, no preceding fever or infection, no history of visual loss, dizziness, no history of involuntary movement, uprolling of eyes, urinary incontinence, no history of sensation loss, no history of loss of bowel and bladder. Now coming to past history, he had history of rheumatic fever at the age of 12 years with joint pain and fever and was treated with penicillin prophylaxis. There is history of percutaneous balloon mitral valvoplasty done in 2020 for severe mitral stenosis, and he was thus to follow up since last 3 months. There is no history of diabetes mellitus, hypertension or stroke, no history of ischemic heart disease, tuberculosis, asthma, reactive aero disease or seizure disorder, no history of previous hospital admission apart from balloon mitral valvoplasty. In family history, he lives with his wife. He has only one daughter who currently lives separately. There is no family history of stroke, cardiovascular disease, or neurological disorders. In diet, it is mixed diet, appetite is normal, able to perform activities of daily living until onset of weakness. Sleep was undisturbed. Bowel and bladder habits is normal. Smoking and alcohol denies usage of them. In medication history, there is long-term anticoagulation with warfarin. Last INR check was unknown and was prescribed digoxin and diuretics but reports irregular compliance. No known drug or food allergies. Now, coming to the general physical examination.
Wait.
I think we'll stop now and we'll evaluate the symptoms one by one, right?
Okay, sir.
Akif, even like, hello?
Yes, sir.
Akif, I'm audible?
Yes, sir. You are audible.
Yeah. So, first, you talked about the complaints. So, your first complaint was palpitation on and off since 1 week, right?
Yes, sir.
Yeah. So, can you use a medical term in your chief complaints?
Sir, palpitation is, sir, we cannot use the medical terms in chief complaint.
Exactly. So, the first, like, so this presentation, I wanted to help you on a longer run. So, we'll just see what mistakes you can do and we'll try to avoid them as much as possible. Everything is learning, you don't have to worry. Okay.
Okay, sir. So, what will be,
Hello?
sir, used in here in case of palpitation?
Yeah. How would you say palpitation? So, you can tell
What did
unpleasant
the patient tell
sensation.
you?
Okay, sir.
What will the patient tell you?
Okay, sir. Like racing of
What is
heart.
Yeah, that is what you are supposed to say. Whatever your patient said, that is what you are supposed to say. So I
Exactly.
am sure that patient did not say palpitation.
Yes, sir.
So, you should say unpleasant awareness of his own armpit.
Okay, sir.
Okay. So, like if old age examiners come, they'll be very particular on what you mention. Okay. Right. Okay. So, can you analyze only your present
Before
illness?
this also, don't mention name of the patient, please. In your history, just at the beginning, you mention name. No,
Yes, sir.
don't mention.
Okay, sir.
Yeah. Okay. So, you said patient describes a sense of air hunger, right?
Yes, sir.
So, what do you, and I mean, what is that? Can you elaborate?
Most likely, sir, it might be due to the palpitation part. He was
Mm-hmm.
he was feeling that he was not able to take air completely.
Okay. Okay. Fine. And this palpitation related history, what you told was very nice. Like, what it is rapid and irregular. So it points out to some etiology, right?
Yes, sir.
Okay. So how do you link a palpitation and a stroke,
Sir,
like the next complaint?
sir, most likely this palpitation is of atrial fibrillation as the symptom goes, like rapid and irregular, and
Hmm.
and it may precipitate a cardioembolic phenomena, most likely embolic phenomena, sir.
Okay. Okay. So next thing is like you told, right upper and lower limb weakness started abruptly.
Abruptly, sir.
So what is an abrupt thing? And again, in the fourth line, you again mentioned it. It was insidious in onset,
Sir, sorry, sir, it was
right?
not, sir, abruptly announced. It was sudden onset.
That is all. Sudden in onset. That is all. These tiny things, no, a little senior examiners tend to hold them up. So make sure you don't have all these mistakes. Okay.
Yes, sir.
So what if it is progressive? What if it is sudden? Why is it so important? Why is the onset so important?
Sir, it points towards the etiology to which we are dealing with. Gradual
Uh-huh.
onset can be such specific occupying lesions or demyelination. Sudden onset can be, sir, ischemic
No,
even or
no. Demyelination is not gradual onset. Demyelination generally is of a sudden onset. And if it is a sudden onset, what would you expect? The most common etiology?
sir, ischemic phenomena, ischemic stroke, sir.
No, you use better vascular.
Okay,
So
sir.
you expect a vascular event. Okay.
Okay.
Yeah. So right upper and lower limbs, right?
Yes, sir.
He had weakness of his right side. Okay. Then you told he had difficulty in what do you call holding the glass of water,
Yes, sir.
right?
Yes, sir.
So what would cause that?
Sir, most likely it is a distal weakness initiated first, followed by there is a proximal.
S- No, no. What muscles do you need to hold a glass of water
Sir,
in general?
lumbricals and interosseous.
Is it the lumbricals and interossei which are needed for holding a glass of water or your flexors of forearm?
Sorry, sir. Lumbrical interosseal with fine movements and for
Exactly. So to hold a spoon, you need your pincer movements.
yes,
Okay. So holding a glass of water would be okay. It is not such a skilled movement. So people tend, like if you are dealing with a case of a CNS,
yes,
you
sir.
should ask more of skilled movements.
Okay, sir.
Like, for example, he was unable to hold a spoon. All these would be more helpful. Okay.
Okay, sir.
Yeah. Okay. And Speech, your history was nice. You told that he understood the what do you call words spoken by his wife. Okay. So now, like from your history and everything, excluding the negative history, neurology is everything about localization. Okay. So where do you like to localize the lesion? Only based on your present history.
Sir, it is most likely uh, subcortical in location because there is
Okay.
no history of seizure. Sir,
Okay.
there was also not
Okay.
dense hemiplegia. It was progressive, so it is not likely cortical in origin. Then there is as well aphasia along with weakness. So most likely, sir, it is MCA territory cancer.
Okay. So you think this is aphasia? What patient is having?
Because the patient was not able to speak properly, sir. So most likely this is aphasia.
Mhm. Okay, but inability to speak can be aphasia, it can be dysarthria,
Yes.
right? So don't land up on your diagnosis so early. Okay.
Okay, sir.
So any other cranial nerve symptoms? Nothing, right?
No, sir. No other cranial nerves.
Okay. Now coming to your past history, I think Akif, are you available? Hello? Hello? Right, okay. Deep sir, आप है क्या?
Yeah, I'm good.
Yeah, yeah. Sir, like past history, rheumatic fever at the age of 12 years. Can you mention that? Yes.
Yeah, I so if patient is saying clearly that I had rheumatic fever, then it's okay. But I think he had a long history of fever with joint pains and
Yeah,
all
so
would the way
exactly,
of
sir. Even
explaining.
I was thinking about that. Like what no patient will remember what happened at 12 years of age.
Okay, sir.
Yeah, so maybe better way of
Mhm.
saying is he required injections for this much
Uh,
time at time, and that way you can try to explain that it was.
exactly.
Yes, sir.
Yeah. So this has to be corrected. Okay. And okay, he had his mitral
This
valvotomy
is
done.
all about what patient is telling you. You should not use your terms. Only at the end of history, when you are summarizing your thoughts, that I think these all things happen, there you can use your terminologies. But otherwise, whatever patient says, there's those are the words that you have to use in history.
Yes, sir.
Okay. Right. Any relation to family history and stroke?
Yes, sir. Like if it is a thrombotic, there can be family vasculitis, like can be in the rare causes. There can be, sir.
Mm-hmm. Mm, quote one example, like what family history will be positive.
Homocysteine, sir, can family issue.
Exactly. Very good. Yeah. And any other possibility?
Sir, protein C, protein S division. Yes, sir.
Okay, so more of pediatric strokes tend to fall under that.
Okay,
Okay. Pediatric strokes are one more. So cardiac, you are supposing as of now it's a cardioembolic stroke is your provisional what do you call summary based approach, right?
yes, sir.
So you think okay, fine. Okay. How is personal history linked?
The personal history to identify the patient status, sir, because for if there is smoking history, we can consider changes.
Exactly. Considering his age. Yeah, very good. Okay. And
And sir, regarding also bowel and bladder involvement, present or not, can also just, sir, what is the area of the zone?
okay. So can a stroke present with bladder and bowel?
Sir, if there is paracentral lobe involvement, ACA territory.
ACA territory. That's good. Okay. Yeah, medication. Next comes to medication history. Yeah. Okay. He's using warfarin is what you say, right?
Yes, sir.
Okay. I think even this deep sir, I think it's better to use blood thinners, right?
Yeah.
Instead of
I
using
mean, actually,
warfarin.
patient is clearly very clear that my warfarin, I was using warfarin tablet, then it's okay. But I think we should avoid using such terms in exam.
Excellent. Okay. So nice. You elaborated the history well. That's good. So as of now, we are still thinking it's a cardioembolic stroke, which is having a subcortical thing, right?
Yes,
Okay. So before that, he had a fall, right, while getting up.
yes, sir.
So
Yes.
can this be a traumatic stroke?
Sir,
So
But there was when you said there was nothing like yes, sir, there can be also possibility, but there is no history of ear, nose, or ear, nose bleed when it discharges. One negative history was which was going against it, and it was progressing in nature. Like
Okay. So yeah, yeah.
So
Okay. So,
you should not keep your history ambiguous. Either you make sure while asking that whether the fall was before or what, and if at all the patient fell down and then only he noticed his weakness, then you always keep that it can be traumatic in nature also, because you don't know what exactly happened and all. So I understand your point that it looks like embolic only, but traumatic should all, if the fall was first, you should keep thrombotic also as a DD as of now.
yeah. Yeah. So whenever there's a fall, like this can be a wake up stroke. Like it's not an early morning wake up stroke, but he slept at 2 p.m., got up at 4 p.m., and then had a fall. So you need to justify in your history itself that he had a fall while he was trying to get up. You mentioned that. So what comes is the did the fall lead to neurology or neurology led to fall? That we'll have to sort out. So you'll have
That
to
is
make
very
sure.
important.
That is very important because did he have any giddiness? Did he have a seizure? All that you mentioned, you need to be more clearer at the onset of all. If you summarize that at the in the history level itself, it will help you in coming to your diagnosis. Okay, so next, yeah, so we've gone. Can you summarize your history? I
yes, sir.
mean,
Sir,
mm, just a brief positive points.
Yeah, one more thing I'd like to ask you. See, one
Yes, sir.
thing, yeah, you said na, in your history palpitations which you mentioned.
yes, sir.
Okay, so one thing, as rightly said by him, you should not use the term palpitations as this. Another thing, how did you ask the patient whether it was regular, irregular? You mentioned it was irregular.
Yes, sir.
So did the patient said it was irregular, but how did you ask him?
Yes, sir. Like
How did the patient describe that it is
I
irregular?
used to show the patient actually by tapping on the table to show how he felt his heart rhythm was.
Okay,
He showed that it was going
so you
irregular.
demonstrated.
Yes,
So
sir.
So that
basically, you
is a good
demonstrated,
answer.
and
And
he said okay to that.
yeah, your answer is right. Whether you asked or not, it is not important. But your answer should be like this only. Patient himself told me by doing dug 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 dug, or he tapped on
Correct.
the table and he told me. That is very important because
Yeah. Yes.
otherwise, knowing that it was rapid, irregular, all these things by just asking questions is difficult to know. So your answer
Yeah.
was very right. The patient told me like this. It was like that.
Yeah. That's a good thing. Very nice. You clearly told that. Right. Okay.
Another thing
Yeah.
is you mentioned in history na, that he has a past history of balloon valvotomy and all. So did the
Mm.
patient or attenders use the terminology, or you after seeing the reports you have mentioned
No,
that
sir.
in your history?
Attendant herself told that he was admitted in hospital for it for this.
Okay, but
Yeah. So in this
did he
case
say
also,
did
we
he say
should
you it
use
was severe mitral stenosis? That terminologies may not be said by a normal person.
Accepted.
Severe
Yeah.
MS
But
and all.
that was not told. Specifically, it was told that some balloon was inserted into the valve. That was the two cups valve, like was there.
that is what
Okay.
you are
Yeah.
supposed
So
to
then
say.
you have
That
to
only this is
demonstrate it
mistake.
like that only, and then you can say possibly it may be that, but you cannot accurately say na, which procedure they have done. Exactly, you have mentioned na,
Yes. Yes.
percutaneous
Yes.
balloon mitral
Yes. Yes.
valvuloplasty.
Yeah.
Unless and until he's a medical field person, no, usually they won't be able to use that exactly as it is. I'm saying. If
Yeah.
they said, then it's okay. If they said it is fine.
Yeah. Yeah. Very nice. I mean, that's a very valid point because no patient will say true.
Yes.
Mm. Okay.
Another thing you said was that warfarin. Yeah, if he said warfarin or attendant said exactly warfarin, then it's okay. And you said INR was not checked, and also these things. If usually the common people and their attenders would not be able to say all that. If they said that, then it's fine. Then so that because make sure of that because few of the time, examiners are very keen on that, and
Yes.
you will get stuck in your history only.
Mm.
So your main goal of your case presentation, especially in DNB, should be that no examiner should stop you in history taking.
Yeah.
If you get stuck here, that means you are in trouble.
They'll immediately jump into pharmacology. They'll ask you all
So if you
unrelated
go
questions.
anywhere,
Once you,
yeah,
if you mention
exactly.
INR, you're gone. They'll ask you everything about heparin, prothrombin and all. So use your
Okay.
terms very judiciously. That's it.
Okay, sir.
Okay. Yeah. Very nice.
The
Yeah.
point
So
is, if you
next.
want your Viva to go to that level, to that part, so you can divert your Viva as per what you want. And if you are really
Mhm.
sure that I want to let them ask me questions on it, then it's okay that you use terminologies like that. But if you are not very sure, then don't use such things.
Yes,
So
yes.
overall, very good, nice summary of history. Sorry, summary is still
Mhm.
pending. You have mentioned your history very well. Some things which are definitely mentioned so far is that don't use patient's words only. Other than that, you did well. Give a summary of whatever happened so far in history. Summary.
Sir, Mr. XYZ, 68-year-old male, right-handed person, presented with complaints of racing of the heart for 1 week, weakness in the right upper and lower limb, and difficulty speaking for 2 days.
Done. Done.
In previous in the background of history of rheumatic heart disease, was treated 5 years back with balloon mitral valvoplasty.
Okay. Valve repair, you can mention. That's it.
Okay,
Okay. Yeah, yeah, yeah. Okay. Fine. Right. So, okay. Now you can go to your general physical examination.
sir. On general physical examination, patient was lying supine on the bed, conscious, cooperative, obeying commands, oriented to time place person, moderately built and nourished, BMI of 23.2 kg per meter square. BP on right arm supine was 122 by 70 millimeters of mercury. Left arm was 126, sorry, it was actually written mistake here, 126 by 74. Pulse rate
Mm-hmm.
is 96 per minute, regular rhythm, normal volume in character. Arterial wall is not thickened. Peripheral pulses oil filled. Equal intensity is bilaterally with no radioradial delay or radiofemoral. Respiratory rates is 20 cycles per minute, abdominothoracic, normal pattern and depth with use of accessory muscle of respiration.
So you said the pulse is regular here,
Yes,
right?
sir. On examination, this time
Okay.
it was regular.
Okay. No problem. Done.
Sir, general appearance was thin, moderately built, alert but fatigue, pallor absent,
Okay.
icterus absent, cyanosis, clubbing, lymphadenopathy, and edema was absent. There is no facial
Mm-hmm.
asymmetry, xanthoma, acanthosis nigricans, no marker of infective endocarditis or neurocutaneous.
Okay. So when you use these terms, they'll ask you what are markers. So what are markers of infective endocarditis would be the next question.
The marker of infective endocarditis are Osler nodes and generations.
Okay. And
The Roth spot, but for endoscopic we need to observe.
okay. Yeah. And the most common location for Janeway?
Sorry, sir.
Hello. Most common location for
Sir,
Janeway.
on palms as well as in the
Mhm.
soles.
Okay. Right. Fine. Are they painful? Janeway lesions.
Osler nodes will be painful and generations are painless.
Yeah. So that question will be asked. What are painful and what are painless? Janeway lesions are generally, not generally, they're not tender. Whereas ocular nodes will be painful. Okay. Yeah. Right. And why do you ask acanthosis nigricans? I mean, why do you see for acanthosis nigricans?
Signs of insulin to look the atherosclerosis if there is presence on diabetic
Okay.
control.
Since this is a CVS bar CNS case, what are other signs of atherosclerosis?
Xanthoma, sir.
Uh-huh.
Then, sir, ear loop creases.
Okay. Anything related with the ear lobule? There's one sign. I don't exactly
So,
remember actually. Okay, just you read up. I think it's in some book. There's a sign. Okay, fine. Right. Okay. You can go into systemic examination.
sir, I will start with the central nervous system first. So, sir, in higher mental function, the patient is awake,
Mhm.
responsive to verbal stimulus, cooperative.
Okay, you can go with the positive symptoms actually. Mm. Yeah, because more discussion would help you all for exams. You're a DNB candidate, right?
Yes, sir.
Yeah. Okay. Yeah, yeah, yeah. Okay. Right.
Sir, higher mental function is apparently normal.
Okay.
Cranial nerve examination is also apparently normal.
You told impaired naming,
Sir, in speech,
higher mental function.
part, there was non-fluent speech. Naming was impaired. Repetition and written output was also impaired, sir. Comprehension was preserved for simple commands.
So naming is impaired.
Most likely, sir, he was facing difficulty in articulating speech.
No, no. See, articulation is a completely different thing, and understanding, comprehension, and all this completely thing. Naming is gone when there is cortical involvement. Okay, so if you are not sure about anything, better don't mention that. Okay,
Okay, sir.
just mention language, non-fluent speech. That's all.
Okay, sir.
Because you know about repetition, you are asking him. Is the repetition impaired?
Repetition was also impaired, sir. Means there was difficulty in repeating the word.
No, like how did you ask him? What did you ask him to repeat?
Like I showed there was glass available in the table in front. I said that there is a glass to repeat it, and he was wandering around the words, like telling, okay, this is you used to showing that it was used to drink like that.
Okay, so this complicates the case. Okay, fine. Okay, we'll see. We'll end. Okay, right. Okay, next.
The cranial nerve examination was apparently normal.
Mm-hmm.
In muscle bulk, both side was apparently normal. There was no atrophy.
So there is stroke and you have normal facial nerve.
Yes, sir.
You
Facial
don't have
nerve
an asymmetry.
there was no asymmetry. There was no um, asymmetry in the upper and lower facial movements, sir.
Okay, okay. That is a little unusual. It pushes the lesion more down. Okay, fine, no problem. Mhm. So why do you generally get facial nerve palsy? A UMN facial lesion in strokes? Why is it that you don't see the other nerve palsies?
Was not sure about it, sir.
Okay, fine. Okay, right. Next, I'll let you know at the end. No problem.
So
You can
don't know,
proceed. Yeah.
sir. Just say that I don't know and let the Viva go on. Don't get stuck or give random answers here and then you will get stuck there only. Just say that I don't know the answer. That is fine to say and let the Viva go on. But go and read. It is very important. Facial nerve palsy in stroke patient. There
Stroke.
is cortical present. You should read about it. It is very important.
Okay, sir. Muscle tones are reduced in the right side, in the upper limb, as well as then the lower limb. It was whereas normal in the left side.
Okay.
Coming to the power, sir. Elbows and wrist, the
How did you get bulk?
sir, bulk is so sir measurements, sir.
Okay, okay, done.
Sir, power, sir, in the shoulder, in the elbows and wrist, it was 2/5 in left side, whereas it was 3/5 in shoulder. All the range of motion, flexion, extension, abduction, and in lower limb, it was left side 4/5 in the hip, and in knees, ankle, it was 3/5.
Okay.
In superficial reflexor, right side plantar was upgoing, whereas left side it was downgoing, and sir, abdominal reflex was absent in the right side.
Mhm. Okay.
Sir, in hip tendon reflex, this will be sir left side. Left side was normal. Right side was 3 plus. Biceps, tricep, brachiolateral, knees and ankle, and left side was normal.
Reflexes. Okay. Mhm.
Sensory system examination, sir, pain, touch, temperature was normal in both sides, and deep sensations of vibration was intact. Proprioception was intact. 2-point discrimination, stereognosis, trapezoid was normal, sir, compared to both sides.
Okay. So is the sensory more examination coming first or the motor?
Sir,
What's the
motor,
sequence?
sir, motor.
No. During our ND times, it was sensory which was first. Okay.
Okay, sir, I will recheck.
Right. Okay. You just recheck that. Like you have a standard pro forma, no? In general. Just recheck that. And so you're telling me you're getting exaggerated reflex within 2 days?
Sir, it felt like there was exaggeration.
Okay. Okay. Right. And your plantar response?
Plantar upgoing in the right side.
Okay, you got it up going on the right side. Okay. Right. Okay. So did you miss anything? Like you've seen motor system, you've seen sensory system. Is there anything else
Sir,
in CNS?
meningeal irritation, there was no signs of meningeal irritation. Gait was unable to, he was unable to work without support.
What
Okay.
about
Oh, there's one more important structure.
Cerebellum, sir.
What happened?
Yes, sir, missed that part.
They'll see the old examiners will be very particular on your case sheet, especially if you're a DNB. I don't know how DNB is now, but every point in case sheet they used to see when we were students. So at least mention it in your what do you call case sheet. You see, sir, if he doesn't see cerebellum, he'll get incoordinated, not you. Okay. So make
what
sure
about
you have.
Sir?
Yes, sir. Continue, sir.
am I audible?
Yes, sir.
Now, yes, sir.
Yeah, what about tone of the muscles?
Tone, sir, it is reduced.
Tone is
Redu-
reduced and you got an extensor plantar.
Yeah, exaggerated deep tendon reflexes with reduced tone, hypotonia.
That's not possible.
Hypotonia with exaggerated DTRs. That's what you are saying, no?
Yes, sir.
Tell me the conditions where it happens.
Sir, I will recheck, sir.
Yeah. Okay.
Yeah, so you cannot have a wrong examination point. These two things are contradictory to themselves.
What you
Reduced
say?
with exaggerated deep tendon reflexes. So I think you must check that. And this mistake, they will keep pushing for this. That
Yeah.
how is it
See,
possible? Like
exactly. The examiner will try to see where you do a mistake, and your mistake should not be like illogical. So you told there's an exaggerated plantar, you told there are exaggerated reflexes, and you're telling me the tone is low. Instead, you can what do you call substantiate by telling plantar is equivocal. You can give up, but you should not mess up. That is what DNB exam is. Practicals are that. Okay, fine. Okay. So now we are going to CNS examination, right?
Yes, sir.
Yeah. Okay.
Coming to CBS exam, general inspection, ABP is normal, non
Mm-hmm.
elevated. There is no
Mm-hmm.
clinical signs of pedal edema, sinuses. Precordium is no visible pulsation of precordium. Sir,
Mm-hmm.
on palpation, apex beat was located at right medial to the mid, tapping in nature. Sir, there was no thrill and parasternal heave was absent. There was
Okay.
slight left displacement of cardiac dullness on passion. Auscultation,
Mm-hmm.
S1 was loud, S2 was normal. There was murmur present, mid-dystolic murmur at the apex in the left lateral position. An opening snap was heard just after the S2.
Okay.
Gas system examination, respiratory and GI system examination was apparently.
Yeah, 1 minute. Your cardiology examination, just go again from start. From inspection part. Now, just show me the inspection part now, which you mentioned. The inspection part you mentioned here also peripheral sense, no pedal edema. Is it like that? You have already mentioned general examination. I don't think it's required here. You should not mention that one thing.
Okay.
Peripheral is not required in the CBS.
Okay, sir.
So that one thing. JVP said normal.
And JVP, you just mentioned normal. You don't have to say not elevated, and you don't have to say indicating no signs of right heart failure. See, that should be your what do you call? If the examiner asks, why do you think JVP? Why do you check JVP? Don't mention anything in the case sheet. Because writing a case sheet without seeing continuously 4 long cases would take a lot of time. Don't unnecessarily increase your time. Okay.
Okay, sir.
Mm.
You said JVP normal, you could have left it like that. No, it's not required to
Yes.
mention not elevated and all.
Okay, sir.
Yes.
But what do you expect do you expect any changes in JFP in your case?
Yes, sir. As there was history of palpitation present, racing heart present, there can be, sir, AOF changes, like atrial contraction
Okay.
can be.
But in your pulse at present, it was regular, no?
It
It
was
was not
regular,
AFib.
regular, sir.
Okay. So you won't expect an absent AFib here, right? No? Okay. Anything else you will expect?
Sure about it. Sir,
Okay.
hepatojugular reflex.
Hmm. Okay. So that one you can do. Okay. So next go to that part. The part palpation you said. Okay. One thing on that apical impulse you said. That's a strapping type you said.
Yes,
What are the other type of apical impulses?
sir. Apical impulse can be, sir, based on type divided into hyperdynamic sir. Sir,
Hmm.
having apex bit and, sir, tapping apex bit or double impulse apex bit.
Okay. So where do you get double apical impulse?
Sir, double apical will be seen as HOCM, sir.
Okay. Any other causes? Only one? Only HOC.
Other I am not aware about.
Okay. Okay. So you should be aware of that also. Other causes are AS with AR. Okay. Left bundle branch block and severe concentric LVH. That is also one cause. Okay. And in this, you said a tapping type of apical impulse.
Yes, sir.
So tapping is which part of the ventricle you felt here in this case? So I meant to ask why you got the tapping apex impulse is tapping type you said, no?
Yes, sir.
It is because of which structure in the heart in your case?
Sir, most likely it is due to, sir, left atrial contraction, sir. During the mitral stenosis, there is a forceful left atrial contraction which causes a tapping apex.
So tapping is because of that normally.
Sir, I will read
So
it.
usually apical impulse denotes what? Which part of heart as such? Apical impulse. Usually I'm saying not in your case. Usually which part of like in apical impulse you feel some part of the heart no? On the chest wall. So which part is it? Is it right ventricle, left ventricle, right atrium or left atrium? Which part you feel?
Sir, I'm not sure.
Oh. So it's apex, no? LV apex, left ventricle apex you feel there. So normally is there. In case of mitral stenosis, you do not feel LV apex, you feel the mitral valve itself. Because mitral valve is very much calcified and all, no? So because of the sudden closure or sudden opening of that, you feel that. Loud S1 is there, no? So it is palpable as a tapping type of apex.
Okay, sir.
Okay, so that is that. Okay. And what else?
When do you feel the apex beat? During the systole or during the diastole?
During systole,
During systole. Why do you feel the apex beat?
sir, because of the rotatory motion of the left ventricle during systole. Apex
Which rotatory? See, like some examiners, they like few terms. If you use the word dextrorotation, no? They'll they'll give you better, easier questions. Okay. Just see why apex beat occurs. That's also an important question. Especially if you get a child case with congenital heart disease or any defects, they'll ask you a lot about apex beat, especially in DNB. Okay. Yeah. Okay. So
Apical all the types also.
Yes, sir.
Apical impulse, everything about it, why it happens normally and when it is abnormal, what is the reason why it is felt like that. All these things are important. So you should rate apical impulse in detail. That is what Akif is trying to tell you.
And you know about triple apical impulse? You heard about that triple apical impulse?
Not sure, sir.
So just read that, na? Apical impulse also. Just
Okay.
read all the types of apical impulse. So basically, you mentioned few, one is tapping type, hyperdynamic is one. Other is the heaving type, and double apical impulse, triple apical impulse.
Okay, sir.
And there is one more called as retractory apical impulse. So you should know all the apical impulse and causes of it. If somebody asks you, you should at least be able to say 2 or 3. 3 minimum you should say.
Okay, sir.
You cannot stuck at one place. So what do you think this murmur is? You said a mid-diastolic murmur. You described the murmur properly, everything. Just describe again the murmur.
So it's a low pitch murmur, sir. Rumbling murmur. Heard at the apex, the left lateral position.
Can you draw this on the
That's all.
page?
Okay.
Can you draw this? They will want you to draw this on your examination sheet. What is the type of murmur? Make sure that you know how to draw it in S1, S2, where is the murmur and what is the thing, everything. Okay.
Okay, sir.
Keep continue.
Palpation.
Sir, rest system examination was normal. Diagnosis, basically acute ischemic stroke involving the left middle cerebral artery territory, presenting with right-sided hemiparesis. Underlying cause can be
Okay.
atrial fibrillation.
Go up 1 minute. What is your diagnosis?
Sir, acute ischemic stroke involving the left middle cerebral artery territory, presented with right-sided hemiparesis, non-fluent facial. Sir, underlying cause can be the atrial fibrillation.
Oh, you want to say MCA territory and dominant frontal lobe. So you think this is the Broca's aphasia? Okay. Mhm. You think that is logical? So you tell because of Broca's aphasia is having impaired naming and repetition. In Broca's what happens? Is naming and repetition gone? What happens in Broca's? So in Broca's you have a broken speech. Okay. So only the thing is you have your comprehension intact. Your repetition will be lost because your conduction fibers are gone. But naming is doubtful. So don't complicate your case.
Okay, sir.
Okay. And embolic strokes generally don't tend to like have a they tend to have more of a subcortical involvement only. When you say subcortical, Broca's should not be your diagnosis, right? Because Broca's, Wernicke's, all these are more of cortical involvements, no? So when you put in a diagnosis, make sure you don't complicate it.
Okay, sir.
Okay, you can say right-sided hemiparesis with involvement with what do you call speech abnormality. But don't mention Broca's, Wernicke's and all when you are doubtful about it.
Okay.
Instead, you can leave because the examiner tends to overlook this. If the examiner overlooks it's okay. Now see, what you mentioned and what you wrote is exactly the opposite. Okay, right. So you mentioned the left MCA territory. No, they'll ask you about. So now we'll discuss what's important. So now this patient came to your ER. He came to you, and okay, underlying cause you mentioned. You first finish the case. We'll see. You
Underlying
see
cause,
atrial fibrillation. Hmm.
and there is contributory condition with the rheumatic heart disease.
Acha. Okay. Right. So what's the most common cause of
Cardiac
atrial fibrillation?
hypertension.
Sir?
Most common cause of atrial fibrillation? Are you audible?
Yes, sir.
Am I audible?
Yes, sir.
What is the most common cause of AF? Leave this case.
Sir, it can be, sir, non-modifiable causes like age. Then, sir,
No,
cardiac causes, sir,
no,
ischemic heart disease.
no, no. What's the most common cause? Hyperthyroidism.
Okay, sir.
Yeah. The most common, first you mentioned the reversible causes, no? It will be hyperthyroidism. Okay, fine. So atrial fibrillation and stroke. So how do you diagnose a patient? Like for suppose if this patient is not having rheumatic heart disease and he has an AF and he has a stroke. It's a 65-year-old male. So how would your approach be?
Sir,
How would you treat the patient?
sir, for
Patient with AF and a stroke.
yes, sir. For
How would
sir, sir, treatment strategy will be to prevent, sir, antiarrhythmic with for antiarrhythmic rhythm rate control and rhythm atrial fibrillation part. For the stroke part,
Okay.
we need to go for thrombolysis. First of all, we need to check for sir imaging it to rule out whether there is septal vein.
Okay.
Then we'll go for thrombolysis.
Okay.
Post thrombolysis, sir, we will also check for imaging whether there is bleed, monitoring and workup for
Now,
arterial.
for suppose patient came out of window period, you have no option. You're in a subcenter, you don't have endovascular intervention.
Yes,
So
sir.
you have an AF patient with
Okay.
stroke and he came after 8 hours. How would you manage?
Sir, I need to rule out. First of all, I would need to put the red flag things. I will rule out whether there is any clot present or not with echocardiographic imaging. Then, sir, I will go for rate control and rhythm control, and following which anticoagulation
Okay.
based on chat versus.
Ah, that is what we want. You've been waiting for Chadwell score. Yeah. Okay. So Chadwell score, how do you calculate?
Sir, based on such
Makes
is itself the mnemonic, congestive heart failure, hypertension. Their A is
yeah,
for 2 points, sir, age more than 75 years. Then, sir, D
very
for
good,
like
very good. So how do you calculate the bleeding risk while
has,
prior to putting?
has blood scores, sir.
Okay, right. Okay. So how do you know? You told your patient had regular rhythm, and based on your history, like for suppose remove rheumatic etiology now.
Okay, sir.
Based on history, if you say he has a what do you call unpleasant awareness of his heartbeat.
Yes, sir.
So AF, and when you examine, it's regular. How do you approach? How do you confirm?
Sir, I need to do for a electrocardiogram, sir, to check for the rhythm. And if it is
So
normal,
ECG is normal, no?
yes, sir.
Because Mm. So
Sir,
patient is saying irregular heartbeat. You are having regular heartbeat. How would it?
sir,
How would you catch the irregular fellow?
I will go for sir Holter monitoring.
We want that answer. Holter monitoring.
Okay,
Okay, right. Uh, Okay. How do you classify stroke? Do you know any classification systems? Hello?
yes, sir.
Hmm.
There is a classification, sir. Like I can classify based on etiology, sir, like ischemic stroke or hemorrhagic
o-
stroke,
Okay,
sir.
that's nice.
And there is one, sir, based on like size, yeah, categorizing of ischemic stroke. We can go for sir those classifications, sir.
Very good. Very good. TOS classification. Right. So what is TOS classification?
Sir, here we check for what is the like whether it is large artery atherosclerosis, cardioembolism, small vessel, or of undetermined etiology, sir.
No, no. Now it is large vessel, cardioembolic, small vessel, determined and undetermined. So we have five. Okay, right? And what does determined mean? What is the most common type of stroke among these?
Sir,
Among
most,
in the toast?
sir, I'm not sure of it.
Within the toast? Okay. So within toast, it is cardioembolic, which is most common. It constitutes about like 40 to 45 percentage. And then comes large vessel and small vessel. Okay. Yeah. So you do a Holter monitoring a minimum for 24 hours in a stroke patient, ideally. You do an EKG, you do an echo, and you get a CT or CT angio or an MR and MR angio for a stroke patient. Okay. So, large vessel is atherosclerotic, right? So, what can cause large vessel strokes or stenosis?
There can be sir underlying diabetes, sir, there can be
Okay.
also sir, smoking,
Okay. Fine. So, which valve is most commonly involved in valvular AF?
mitral valve, sir.
Mitral? Yeah. Okay. Is it? Yeah. Okay. Fine. So how do you treat, do you use NOACs in valvular AF?
No, sir, we go for the old ones mainly perfect.
Why? Is there any specific reason?
Sir, there is not a large centric study for it.
Very good. Very good. Okay. Okay. Right. So can you mention other risk factors for cardioembolic stroke? Leave rheumatic fever? Any other risk factors?
Sir, infective endocarditis.
Okay,
Sir,
more.
like
See, anything if anyone asks, just always remember vascular infective tumors. Okay, or hereditary. So all these you can quote some examples of all these.
okay,
Okay. So what? Let's go with neoplastic lesions. What can cause cardioembolic?
left atrial myxoma.
Yes. Okay. Vascular?
Vascular, sir, can be due to vasculitis.
No. No. Cardioembolic stroke and vasculitis? No.
I will
Vascular is coronary artery disease. Like if there is an LV aneurysm, if there is an LV thrombus, all this can happen. Ka? If there's a dilated cardiac myopathy.
okay, sir.
Okay. Right. And uh, any aortic causes?
Sir, aortic might present.
Very good. Very good. Aortic dissection might be. Okay. And very good. So cardioembolic stroke, you almost told all the answers. That's good. Okay. And so rheumatic heart. Now, for suppose there's a child who came with a stroke. Would you thrombolize the patient? An 18-year-old, same history, post mitral valvotomy. Yes, you thrombolize.
Okay, sir.
Okay. So a patient on warfarin, you want to thrombolize. What would you do? How much should the INR target be?
Minor target will be 2 to.
No, no, not that. If you want to thrombolize a patient who's already on warfarin,
Yes, sir.
what is the contra? Like, when would you stop? Now they've changed it.
I will recheck, sir.
So if, yeah, no, no, I'll tell you, no problem. If it is less than 1.7, you can go ahead with thrombolysis.
Okay.
The INR should be less than 1.7 if you are thrombolizing the patient. Okay. So what is a lacunar stroke?
Sir, small deep,
Hmm?
small
In which,
subcortical infarcts.
don't mention subcortical. Lacunar strokes can be anywhere. It is because of lipohydrogenesis.
Okay, sir.
They generally occur in M1 stenosis and all. Okay. Yeah. Okay. Do you know what are lacunar presentations? This is an important question. You have it in your Harrison.
Can be, sir, pure motor,
Very good. Very good.
ataxic, and dysarthric.
No, 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 no. Mention it correctly.
Sir,
Pure motor, pure sensory,
sensory motor, ataxic hemiparesis, dysarthria, and
clumsy
syndrome.
hand. Dysarthria, clumsy hand. Very good. Okay. Right. And what's the most common cause of stroke in India? Ischemic stroke. No, no. Most common cause of ischemic stroke in India is large artery atherosclerosis. Very good. Okay, can you tell me any non-atherosclerotic vasculopathies? It's a common meme nowadays. You get it in the background. I'm giving you a clue.
Circular meaning.
Okay, that's very nice. Moya moya.
Okay, sir.
Never forget moya moya. Okay, so vasculitis, you can have primary or secondary. Primary is isolated CNS vasculitis and all. Secondary is when you have all the spectrum of diseases like giant cell arteritis and all. Okay. Sir, Deep sir and Akif, if Akif sir, please
Yes,
involve.
yes.
I'm asking because this is neurology, that's it. You
Yeah,
can
yeah, no
stop
problem.
me
I
anytime.
thought
Please,
I thought
please don't mind.
I let you finish neurology part, then I'll ask cardiology part.
Acha, I'm done almost. Like, I mean, he's done a very good history. This is it.
Okay.
That's it. Okay. Hmm.
Uh, so one more thing, like to ask, you didn't mention in your diagnosis about the cardiac thing, no? Like you said a murmur was heard, but what it is exactly you didn't say. So cardiac wise, what do you think the patient has?
Sir, most likely, sir, there is mitral stenosis present, sir. Goes to the marrow vein.
Residual. Residual means what?
Means there was,
Like you are saying it's mild, moderate, or severe. What do you think based on your history?
sir, as there was history of valvoplasty done, that most likely it was severe mitral stenosis.
No, that was previously. No, now I'm saying now what he has.
Sir, most likely. Sir, I will check it, sir.
Okay. So you said no? The opening snap is present. You said no?
Yes, sir.
You said loud S1 is there.
Yes,
Opening
sir.
snap is there.
Yes, sir.
Murmur is there. And you said the S1, the opening snap was immediately after the S2.
Yes, sir.
So that what you mean to say. So how do you grade severity of MS clinically?
Based on the sir opening snap and S2 gap, sir.
No, opening snap will not tell you severity. It will just tell whether the valve is pliable or not. So one is the opening snap, but not the opening snap. I'm saying what exactly do you see? It is S2OS gap. Na? You're
Yes,
aware
sir.
of it? S2OS gap,
Yes, sir.
the distance between the S2 and the opening snap.
Yes.
So what happens with CVRT? The gap increases or decreases?
Gap will decrease.
With CVRT, the gap decreases. Why? Why does it happen? You know the pathophysiology of it, of opening snap.
Sir, because with severity there will be high left atrial pressure. It will reduce the gap between the sir S2 and S.
Okay. So more will be the left atrium pressure. So very early the gradient will increase. So LA-LV gradient will increase and the valve will open. Okay. So when will it be absent? Opening snap is absent. Suppose MS case is there, opening snap you are not able to get. What are the causes?
Sir, the patient can be in presently at atrial fibrillation, where opening snap cannot.
Okay. Yeah, good, good, very good. Next.
Severe calcified sir stage of mitral stenosis, later stage, opening snap might disappear.
Calcified. Okay, very good. Next. Anything else? More common than this. These two. These two are pathological. Any other physiological causes?
Sir, there is associated mitral regurgitation present.
Okay. Yeah, again, that's pathological. I'm asking physiological causes why opening snap could not be heard in any patient.
I have to check, sir.
Yeah, so mostly because of obesity. Na? Sometimes the patient is very obese, you may not be able to hear that sounds very properly. Okay, and after S2, you're getting a sound that is OS, opening snap. Na? How do you differentiate opening snap with S3? It can be S3 also. No? So, how do you differentiate opening snap with S3?
Sound is like.
There's no issues, just write down.
Okay, sir.
If okay. Answer it. If you know the answer, tell me. Otherwise, you write down this question because this will be asked by examiners.
I will
Definitely.
check, sir. Most likely, sir, that sound is like click-like sound will be in opening snap, but pitch will be higher in opening snap compared to the.
To listen to S3, you require the bell, no?
Yes, sir.
Hmm. Okay. And your history was this was contradictory because you said patient was having palpitations. Here it was regular, but it can be paroxysmal. You know what are the types of atrial fibrillation?
Yes, sir.
Yeah, what are the types?
That it can be fed into paroxysmal AF,
Hmm.
drone AF.
No, that is separate. No? That is separate. Here paroxysmal means what? How do you define paroxysmal AF?
Sir, means which is spontaneously terminate within 7 days.
Okay. Next, other types?
Sir, it can be persistent, sir, and
Persistent. Okay.
permanent AF, sir.
Permanent. And one more is there. You said three. One more is there.
Paroxysmal, persist, long-standing, and permanent.
Permanent. Okay. So how do you differentiate long-standing and permanent AF?
Sir, in permanent AF, it is it will be means there will be rhythm will be permanent and it will be and no rhythm control will be there, sir. Only rate control will be managed in permanent AF.
Yeah. So these are all definitions. You have to tell properly what it is. So basically, permanent means despite of trying all the cardioversion, both mechanical and shock wise, direct cardioversion wise, if you have tried both and still if the rhythm is staying as atrial fibrillation only, then it is called as permanent. That is despite of all the maneuvers you tried, it is rhythm is not reversing.
Okay, sir.
Okay. So long standing is if it is more than 1 year of duration, then it is long standing. and persistent is more than 1 week is called persistent AF. So I'm supposing this case is your mitral stenosis, severe mitral stenosis. So we said suppose a patient of mitral stenosis get atrial fibrillation, will you start anticoagulation directly, or you will see that score only and then only you start
No, sir. We need
anticoagulation?
to start directly valvular AF, but obviously I will look plot present on prior to that.
Okay. So what do you mean by valvular AF? Valvular versus non-valvular AF.
Valvular
So
AF
suppose
is
a patient of suppose I give an example. Suppose a patient of mitral regurgitation getting an atrial fibrillation. Will you label him as valvular or non-valvular?
no, sir.
Valvular. You're saying is non-valvular or valvular?
We will label it as non-valvular.
Non-valvular. Okay. So that's right. So in valvular case, the Stadwork score is not valid. You have to start despite of if MS is there, patient develop AF, you have to start the anticoagulation despite of the Stadwork. Okay. NOACs are not indicated as. So how do you manage this case? Suppose leave of stroke history as this. Suppose this patient was mitral stenosis and came with palpitation and all. So how do you manage this patient? So let's go by how will you investigate this case otherwise? How do you want to investigate? Only for the cardiac part I'm asking, not about.
Sir, we'll go for two categories. Trans esophageal.
Before that, before that, go to your basics. Echo is not for you basically. Go about ECG. What will you expect in ECG? That will be asked to you. ECG and chest X-ray. So suppose ECG is there. What will you expect ECG to be in a case of mitral stenosis? Severe mitral stenosis is there. What will you expect ECG changes in severe MS?
Sir, there will be changes of left atrial enlargement, like P mitral will be there. Broad POFs and will be seen, sir.
Anything about rhythm?
Rhythm, sir, atrial fibrillation found here, sir. Case of severe mitral stenosis. And we can also get, sir, severe cases if there is pulmonary hypertension, sir, we can get right ventricular hypertrophy.
Okay, good, very good. Okay.
As I
So
told,
you mentioned
go
almost
for the basics first. Only the basics. Don't directly mention echo.
Okay,
They'll get curious. Okay.
So always you start with blood investigations and then ECG, chest X-ray, then echo. Chest X-ray, so ECG mentioned everything. So basically left atrial enlargement will see. You can see for arrhythmias, and if it is very severe and leading to pulmonary hypertension, there will be right ventricular hypertrophy, and you will see the RVH changes. Okay.
yes.
Chest X-ray, what will you see?
Sir, due to left atrial enlargement, sir, there will be double density sign. There will also be spraying of the carina for it, and if there is pulmonary hypertension, can produce the Kylie breed lines. And sir,
Kylie B lines is because of what? Pulmonary artery hypertension or venous hypertension?
venous hypertension, pulmonary venous hypertension.
Okay, so you're mentioning venous hypertension. Okay. You know the grades of pulmonary venous hypertension?
Sir,
based on X-ray, do you know the grades of that?
I know like stages first Kylie B will appear, then cephalization of vessels, then there will be perihilar opacities.
Kylie B is later. The first thing visible will be cephalization. So cephalization, and then we'll see the curly B lines, and last will be that proper pulmonary edema, bat wing like picture which is there. No? So read that. No? Read about X-ray in all the valvular heart disease. You should know about what are the chest X-ray finding in mitral stenosis, mitral regurgitation, AS and AR. Okay, that you should be aware of. So suppose you start him on anticoagulation, like what will be your target of INR target INR?
INR target will be from 2
to 3. And what dietary advice will you give to the patient? Will you give any dietary advice?
Yes, sir. Dietary advice. Avoid, sir, leafy. I mean,
okay. 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 So how old is the patient? Yes,
68 years old.
60 years. Okay. So supposing you want to, so what are the indications of surgery in case of mitral stenosis?
There is signs and symptoms of heart failure present. There is favorable anatomy present. That is, there is asymptomatic patient, mitral stenosis, but with high risk features of pulmonary, like pulmonary hypertension present.
Hmm.
Patient who is not suitable for balloon valvoplasty. One who has mitral regurgitation.
Okay. So management will be in two parts. That you can choose patient on for balloon valvotomy or you can take for surgery. That is valve replacement. Okay. So balloon valvotomy, the valve should be not calcified. It should be very pliable. There should be no clots as well. No left atrial or left atrial appendage clot as well. Okay, so you can read about the indication of surgery. It's a question sometimes means if you go up to this level, that means you have already cleared your exam. These are for your extra bonus marks. Okay. So basically, supposing this patient is not fit for the balloon valvotomy, his valve is very calcified and all. So you are planning for a surgery.
Yes.
That is mitral valve replacement. You are planning. Which valve you will put? You know what are the other options of in valves we have?
So bioprosthetic valve and mechanical
Or
valve.
which one will you choose for this patient?
No idea.
Okay. So you have to read that also. Okay. So basically, it says that if the age is below 50, so you know what is the advantage and disadvantage of both of them? First, then we'll go like that.
No, sir, not specifically aware of ventilated.
Hello.
Hello, sir. Hello.
Yeah. Hello. You can hear me?
Yes, sir.
Yeah, okay. So what I'm saying is, what is the advantages of bioprosthetic valve and what is the disadvantage and advantage? Similarly for the metallic valve.
Not aware of it.
Okay. So you have to read that also. See, prosthetic valve basically is a natural one, na?
Yes, sir.
Hello.
Yes, sir.
Yeah. So durability of bioprosthetic valve is only for 10 to 12 years. So suppose very elderly patient, the guideline says that if the patient is more than 65 years of age, okay, so you should go for bioprosthetic valve
Okay, sir.
because we are expecting the life expectancy to be around 10 to 12 years of him. So we'll put some bioprosthetic valve. What is the advantage of bioprosthetic valve is that you did not need a lifelong anticoagulation
Okay, sir.
because it's natural one only, it's taken from so bovine or pork. So it's a natural one. So it requires only anticoagulation for 3 to 6 months. After that, you do not require anticoagulation. So that's why in patients with more than 65 years of age, bioprosthetic valve is preferred. Below 50 years of age, mechanical valve is preferred. That is metallic valve because it has long durability.
Okay, sir.
Usually for even 35 to 40 years, the metallic valve will be normal only without any problem. Okay, but disadvantages is that patient requires the lifelong anticoagulation because metallic, no, so you have to prevent the clots to form.
Okay, sir.
So suppose in this patient, what will you choose?
Sir, age is more, sir. In such cases, I can go towards sir, metallic valve. Bioprosthetic valve, sir, because age is more because of for this purpose, sir.
You go for bioprosthetic valve. Okay, but this patient has one condition, na, for which he requires anticoagulation.
For atrial, yes, sir, atrial fibrillation was present.
Yeah. So this patient is anyways will require lifelong anticoagulation. Anyways, he requires no for his atrial fibrillation.
Okay, sir.
So
Okay.
for him, there is no point of. Hello.
Yes, sir.
Yeah. So because since he's already requiring anticoagulation, there is no point of doing a bioprosthetic valve. Rather, you can go for directly for a metallic valve
Okay, sir.
because he anyways has to use anticoagulation. So he's a different case as this. Okay. So you read about that. Okay. What are the advantages of bioprosthetic? Advantages of mechanical? Don't think it is for medicine only because it used to be asked in medicine for us also and we used to present.
Okay, sir.
They are very fond of asking these questions. And metallic valves also, there are 3 types of metallic valves. Read about that also. At least the name you should. If you don't know full details of it, the name of the metallic valves you should know.
Okay, sir.
Yeah, I think that's all from my side. So Dr. Deep and Dr. Naveen, you can add if anything else.
So how will you manage his hemiplegia now? What all advice you will give?
Sir, first of all, he was not compliant to medication for this anticoagulant, but we need to ensure that there is compliance as well as adequate advice. I will advise the dual antiplatelet therapy, sir, in the presentation, and sir, as well as sir, statin, sir. And along with sir, I will advise for regular physiotherapy to improve the weakness.
Yeah, sorry, I was not. You said you will give anticoagulation and physiotherapy, right? Mhm. Okay. Any other questions? Okay.
Yeah, I think that should be okay. We can just summarize maybe. Just each of us can give our experience about or advice maybe to how to get more better from it. So basically, I felt, see, in history wise, you should see that the main goal of your DNB exam should be that, okay, in history, they should not stop you. Okay. So your history should be such that you should go like continuously, you should keep on going. Don't give any chance for them to ask you questions. Okay.
Only
Suppose you are
one
not
thing
confident
is,
also, if you are not confident also, just try to speak continuously and speak slowly and don't give gap. Suppose you are telling that there is a history of rheumatic heart disease and then don't give a gap. If you give a gap, it means you are not confident or you want examiner to ask questions. So you give gap only if you are very 100% sure about that topic, then only you give gap. Then only you should be able to answer all the questions.
Okay,
So basically the goal is, if suppose you have finished your history and examination part without much interruption, that means you have cleared your exam.
okay, sir.
DNB also it applies. But if you are stuck in history, that means there is some problem. Okay, and as much as possible, use patient language only. Don't use this medical terminologies too much in history. Even it may be in the
Yeah.
past history also. Anywhere also, don't mention as much as possible. Use common languages as much as possible.
And if, like, for suppose, if you see a police catheter in a patient, you can mention police in situ because
Hmm.
this
Yeah.
patient you all must have catheterized, no? So they'll see, and never miss any findings in general examination. All these old DNB examiners, they like general examination. And if a young chap is coming as their examiner, they'll concentrate on treatment part. So like a treatment, you be pakka. Like they'll ask you how many days aspirin, why clopidogrel, which Novak would you choose, which has bleeding risk, and all this. Okay. On the whole, it was a very decent presentation. So as you present, you'll have more ease. And okay. So okay. So shall we wind up?
presentations because that's how and do present your cases to different people, not to one group of people only, your own consultants or something. Do present to more group of people, you will get more, gain much more understanding of
Question
questions
exposure.
to give
Yeah,
answers.
yeah, yeah, yeah. Very nice. That's a very well done. Such. Okay.
Yeah. Maybe you
Okay.
can take questions
So
if somebody has any doubts.
I don't think so. Okay, sir. Nothing in the comment box, I see. Okay.
Okay, I think we can.
Okay. So we'll wind up. Thank
Yeah,
you,
yeah.
Ashish sir, for giving this, what do you call, revision class for me. Anyways,
No, you should
very
thanks to the
happy to be
presenter.
associated. Yeah,
Yeah.
yeah, yeah, very
Thanks to
nice
the presenter
history,
for
very nice presentation.
yeah. Hmm.
Okay. Okay. Thank you, Deep
Okay.
sir,
Okay,
for
chalo.
being a part. Okay, sir.
Okay.
Thank you.
Bye.